It's a real pleasure and an honor to be here. The lights are off, I can't see you now. But it's a real pleasure and honor to be here. I want to thank Rachel and Michaela for inviting me and the Family Association. In the audience is Dr. Tibaldi, who helped set up this whole tour and did the translation, which is a really fine translation. So it's just a real pleasure to be here tonight. And I'm sorry I don't speak Italiano, maybe next time. What this book is about, it's really a medical mystery. And it's a mystery that I think we as different societies, together, we really need to solve. And here's the mystery. As you know, in the past 20 years, and this is more the case in the United States than it is in some parts of Europe, is we've really embraced the use of psychiatric drugs, antipsychotics, antidepressants, drugs for anxiety. And so, for example, in the United States, roughly 20% of Americans now take a psychiatric drug on a daily basis. And the thought is these drugs are quite helpful and that they represent an advance in care for people who suffer psychiatric difficulties. And the hope is when you get a new medical therapy and you make greater use of those medical therapies, is the burden of that disorder, those disorders, will lessen on society. Does that make sense? And instead, what has happened, notably in the United States, but in other countries, is as we've embraced this paradigm of care, rather than getting a reduction in the burden of disability, we're getting a remarkable increase in the burden of disability due to mental illnesses. So, for example, starting with the United States, in 1987, we had 1.25 million adults on disability in the United States due to mental illness. Now, in 2010, we're now up to about close to 5 million adults, so there's been this fourfold increase. Now, why 1987? 1987 is the year that a drug called Prozac, which I think it's called Prozac is it called Prozac in Switzerland? Anyway, it's the first of these second-generation antidepressants that came to market. So that's why I chose this year. And you see this remarkable explosion in the number of people on disability in the United States. Now, this book came out in English 3 years ago, and since that time I've been asked to speak in a number of other countries, and I'm gathering information about disability rates in other countries. So, for example, this is New Zealand. You'll see that since 1998 there's been more than a doubling of the number of people on disability in New Zealand. This is Australia. You'll see that there's been a fourfold increase in the number of people on disability since 1990. This is Iceland. Now, this data is a bit different. This is the number of people going on disability each year, and you'll see since the mid-1990s there's been more than a 200% increase in the number of people going on disability each year. And now this is Denmark. It's data of the same sort, the number of people going on disability each year, and you'll see that there's roughly close to a threefold increase since 1999. So, and by the way, today, collectively, psychiatric disorders represent the greatest burden of disease worldwide than any other category of disease. So it's now the #1 burden of disease worldwide. So that's the global epidemic. Why are psychiatric problems becoming an ever greater problem in societies, even in this time when we have these new medications said to be so helpful and effective? Now, there may be that data doesn't prove anything about the merits of the drugs, but I think it does raise a question. And this is the question I addressed in this book. How do these medications shape people's lives over the long term? And not just the short term. So drugs get approved, and they get approved by regulatory authorities because they help people over the short term. That's basically why, the type of testing that is done. I'm asking a different question here. I'm asking over the course of 1 year, 2 years, 5 years, 10 years, how do medications shape lives? And not just on the symptoms, but on the capacity to work, socialization, that sort of thing, these functional outcomes that we care about so much. Now, one of the reasons I think this book has gotten some attention, it certainly has stirred some discussion in the United States, and increasingly I am being asked to speak abroad. It's because I think it's the first book that really sought to answer that question, which obviously people are interested in, and looking at what a close review of history and science can tell us about that question. Now, in the book, I look at the long-term course of how antidepressants affect depression, benzodiazepines, how they affect anxiety, what medications are doing for what we call bipolar disorder, and also how do antipsychotics shape the long-term course of schizophrenia and other psychotic disorders. Now, obviously, tonight I can only basically pick one class of drugs, and so I'm going to pick we're going to look at antipsychotics as sort of as a case study. And antipsychotics are a good case study for this reason. If there's any class of drugs where we should be sure to see a benefit over the long term, it's antipsychotics. So within psychiatry, the understanding is antipsychotics are absolutely essential over the short term, and the evidence is quite solid that you want to keep people on the drugs long term. And often you'll hear people say once they get diagnosed with schizophrenia or another psychotic disorder, they're told, you will have to take these drugs for life. They're like insulin for diabetes. Within this whole story of the psychopharmacological revolution, we get a drug called chlorpromazine that comes into asylum medicine in 1955. It's said to kick off this psychopharmacological revolution. So this is a class of drugs at the heart of our belief in psychiatric drugs. And so if there's any class of drugs, the evidence should be quite clear. It should be with these drugs. Now, a big caveat here. The sort of talk, the review we're going to do now in the next 30 minutes, it's not meant to be medical advice, okay? It's just really looking at what we as a society might know about these drugs with the thought that through this review, maybe we can learn to make better use of these drugs, more selective use. That's really the goal here. So please, if anybody is taking these medications, it's not meant to be advice for an individual. It's really a way for us as a society to look at this information. Okay, the first question. Now, I'm a journalist, so I came at this as I've been writing about medicine and science for maybe 30 years. One of my stops in my past, I was director of publications at Harvard Medical School, and there, during that time, I kept hearing this. We have to practice evidence-based medicine. In other words, our practices, our use of drugs, have to be based on some scientific evidence, because there's a sense that the history of medicine tells us it's easy for doctors to be deluded about their merits of their therapies. So we have to have scientific evidence. So the first question is, what is the scientific evidence for the use of antipsychotic drugs, both short-term and long-term? And there's basically two parts to that answer. Going back to the 1960s, this is shortly after the first antipsychotic arrived on the market, which was chlorpromazine. You know it, I think, as Largactil here in Europe. They ran studies designed like this. They would have people come into an emergency room with psychotic symptoms. Half of the people would be randomized to drug. The other half would be randomized to placebo, no drug. And at the end of 6 weeks, the drug-treated patients generally were doing better. They had a greater reduction of psychotic symptoms. And because of that, that's why antipsychotics are seen as effective over the short term, studies like that. Now, the next question, now imagine you're a doctor in the 1960s, you have this new tool, these new drugs. What's your next question? It's how long should I keep patients on these new drugs? And so they ran studies designed like this to answer that question. They would take that subset of patients that responded well to an antipsychotic, responded well to chlorpromazine or another drug we call Haldol. I'm not quite sure the name is here in Switzerland. And so we would take that group of good responders and we would run studies where we would abruptly withdraw the drug from one half of the patients, and the other half we would maintain on the drug, and with great regularity, those withdrawn from the drug relapsed at a greater rate. In other words, they had psychotic symptoms come back, and they often had to be re-hospitalized at higher rates. So what did doctors conclude from these studies? They said, listen, this is why you have to take the drugs for life. They lower the risk that the psychotic symptoms will come back. They say they lower the risk of relapse. And basically what they would say is they lower the risk that the disease will return. And so that was the conclusion drawn from these studies. Now, this is still the evidence base for the long-term use. There was an article in 2002 in the New England Journal of Medicine, and they said, what is the evidence base for the long-term use of antipsychotics with schizophrenia? And they reported to these relapse studies. Now is the next question. Is there any flaw with those relapse studies? Is there anything missing from them? And there's really two flaws you can point out really quickly. One is the design of the study itself. Because today we know what happens was that when you go on antipsychotic, your brain is changed. It compensates for the presence of the drug. And so a lot of what you may be seeing is withdrawal symptoms related to the abrupt withdrawal of that drug. And in fact, we do know now that abrupt withdrawal is very risky. And here's the thing, there are very, very few gradual withdrawal studies in the literature. So when this relapse literature was summarized in 1996 by someone named Patricia Gilbert, she summarized this. But they were virtually all abrupt withdrawal studies. And a very famous psychopharmacologist named Ross Baldessarini from Harvard Medical School said, well, wait a minute. We know that abrupt withdrawal increases the risk of relapse. How about gradual withdrawal studies? What's the risk of relapse? And there was very few studies, but the few studies he could find in the literature, the relapse risk was actually much lower. So there's a certain sense here, this body of literature is tainted by design, okay? By that abrupt withdrawal design. Now the second problem is this. Do these relapse studies tell you anything about how well people are functioning, whether they're working, socializing, marrying, those sort of things? They don't, right? These studies just tell you that once you go on medication, it's really risky to come off abruptly. But they don't tell you how are you shaping people's lives over the long term. And imagine now we had a study designed like this. People with the first episode psychosis come into the emergency room. Half are put on drug, half are put on psychosocial care, but no drug. And now we follow them for 5 years and see which group is functioning better 5 years later, working, etc. The relapse studies don't tell you that, okay? And now, the next step for me as a journalist was this. It's easy to find out that the relapse studies are flawed. So now my next question was, can researchers point me to other literature, other studies, that show that these medications, in fact, are improving people's lives over the long term for people diagnosed with schizophrenia? And in 2002, Emmanuel Stipp, who's a fairly famous psychiatrist from the University of Montreal, tried to answer that question. So he went through the literature, and he said, you can read it in Italian here. He said, after 50 years of using these drugs, are they effective in treating schizophrenia? And you'll see here he says, when it comes to long-term outcomes, there is no compelling evidence on the matter. So for me, this was like a green light saying they don't have that evidence. And then you'll look at the second part of this quotation, and this is a beautiful moment. He says, one thing is for sure, we take a genuine risk in taking a closer look at what has long been considered true, meaning the risk is maybe we're going to find information that is contrary to what we believe, okay? And for me, this was like a green light. It was like a researcher saying, this is a valid endeavor to try to find out what can science and history tell us about this question of how medications shape long-term outcomes. Okay, so now how am I as a journalist going to try to put together this story? Well, I'm going to try to find every bit of evidence I can find that relates to this question of how medications shape, antipsychotics shape long-term outcomes. And the first thing I need to do is try to find out what sort of outcomes were, longer-term outcomes were being reported for schizophrenia in the United States prior to the arrival of the first antipsychotic. Because then the hope is we're going to get this new drug and it will improve outcomes. Does that make sense? Now, this data here came from a conference organized by the National Institute of Mental Health, which is our leading institute for studying psychiatric disorders, in 1956. And they were asking the same question. They were saying, we have this new tool, how are we going to know if it works? And they said, we have to figure out the outcomes we're getting today. Now, if you see here, it's a surprise, because the common wisdom is that prior to the arrival of antipsychotics, people went into the hospital and couldn't come out. In other words, they became chronic. You had a diagnosis, and it wasn't until we got chlorpromazine or Largactil that people were able to live outside the community. And what this data shows you is that's not true. That's a false memory. And what you find in this period from 1945 to 1955 is about 2/3 of patients with a first episode of schizophrenia, in fact, would be discharged within 12 to 15 to 18 months. And then when they followed those people for 3 to 5 years, roughly 2/3 would be living independently out in the community. And this is before we had social welfare systems for supporting people out in the community. Employment rates were above 50%, at this time. So you actually see through this, look back into history, sort of a moment of optimism, where many people could sort of descend into psychosis, with time get better, and 3-5 years later be functioning well enough to be working in the community. And England did a similar study at this time of 5-year outcomes, and here were their 5-year outcomes. And in England at this time, they were diagnosing schizophrenia more narrowly. 5 years later, 33% of their patients in their study just weren't schizophrenic anymore. They had had a schizophrenic time, a schizophrenic episode. Those symptoms had abated, and basically, they were now back to sort of their pre-episode state. There was another 20% of patients that were still symptomatic. In other words, they were still having some psychotic symptoms, but were able to function okay in the community. They could be working, that sort of thing. So in England at this time, where they were diagnosing it more narrowly, more than 50% were still employed. And that's our baseline. And now what we're going to try to do is follow through science, whatever we can find in terms of studies that bear on this question of how the drugs affect long-term outcomes. Now, the first such study was done by the NIMH in the early 1960s. It had 4 arms. 3 of the groups were treated, so people came in the hospital, they had psychotic symptoms. 3 got treated with an antipsychotic. There were 3 types of antipsychotics they were testing. The 4th got placebo. Now, at the end of 6 weeks, the drug-treated patients were doing better. And this is actually a very famous study, because prior to this study, psychiatrists called antipsychotics, they didn't call them antipsychotics, they called them major tranquilizers, sort of the sedative action on people. But after this study, they said, no, they're not just tranquilizers, they're antipsychotic, as if they were antibiotics for bacterial infection. So this is a moment the idea about the drugs changes. Now, but many of the placebo patients got better, then they're discharged and they're followed up for a year. And you can see in this finding, there's a bit of an odd paradox. The three groups which were treated with drugs in the hospital actually had higher rehospitalization rates at the end of 1 year than the placebo group. So you see at this very beginning part of the research literature, the vaguest hint of a paradox. Drugs that are effective over the short term, could they be increasing the chronicity of the disorder over the long term? It's just a vague hint, but it comes up in the very earliest moments of this. Now, the next thing I wanted to look for is what did clinicians see at this time when the drugs were introduced? Because clinicians at this time had some experience with unmedicated psychosis. In other words, before the drugs came in. Now they have these new drugs, and they can see a different clinical course. Now, these comments, these conclusions, this was conclusions printed in a paper by Jonathan Cole, who was the head of the Psychopharmacology Service Center. So I'm not cherry-picking these conclusions. This came from the NIMH, and they're saying, here's what we're seeing. 1, yes, these patients may be getting better faster. We're talking about first episode schizophrenia or first episode psychosis. But boy, are they coming back to the hospital in droves. And they even invented, at least in the United States, a phrase to describe this clinical course. They called it the revolving door syndrome. I don't know if you've heard that here, but that's the phrase they invented there. And then they noticed 2 other things. they noticed that relapse while on drug, if that happened to happen, it was more severe than relapse on placebo. Relapse meaning the return of psychotic symptoms. So for some reason, if it came back, it was more severe. And yet they also noticed that, let's say you go on drug, and now you stop taking drug, people were really having severe relapses then too. So all of a sudden they were seeing some worry about more severe relapses associated with drug use, okay? By the way, you will see the title of this paper, and can you read that title of the paper? It's called Maintenance Antipsychotic Therapy, Is the Cure Worse Than the Disease? And it's because they're worried about these more severe relapses. Now, because of this worry that arose in the 1970s, the NIMH then funds a couple of studies to revisit the sense of how these drugs affect long-term outcomes. The first such study was what is known as a retrospective study. So Sanborn Bachhoven, who was at Boston Psychopathic Hospital, he had 5-year outcome data for people treated in 1947 with psychosocial care, but no drugs. And now he has a similar set of data for people treated in 1967 with psychosocial care plus drugs. And what does he do when he compares those data sets? He finds that the relapse rate is higher, the rehospitalization rate is higher at the end of 5 years in the modern group. And even more important, he finds that the modern group is more functionally impaired. They're much more socially dependent and much less likely to work. So that's his finding from a retrospective study. And here is his conclusions. These are his words. If there's anybody in the audience who doesn't speak Italian, what he's saying here is, if we're worried about long-term outcomes, and you can see he's surprised by his findings, then maybe we need to rethink the use of these medications, because he's saying the better outcomes were in 1947. And you can read his words. This is his conclusion. And I hope you see this as, I am like the journalist who's just going through the literature and finding out as we go through these major landmarks what the evidence showed, okay? Okay, next, there were 3 studies done in the 1970s then, which sought to revisit this question of treating first episode psychosis. By the way, there are very few studies like this in the research literature with first episode psychosis. One was done by Maurice Rappaport at the University of California, San Francisco. And what happened here is people were randomized in this study either to drug or no drug in the hospital, and then they were discharged and followed for 3 years. And you see this? This means no drug in the hospital, and then the patients on their own stayed off the drug in the 3-year follow-up. This meant people were treated with the antipsychotic in the hospital, and then they went off during the 3 years, on their own once they're discharged, okay? So what do you see here? You see that 24 of the 41 patients treated in the hospital without drug recovered from that psychotic episode and never went on drug, never were exposed in 3 years. And it's that group that had by far, where is this? I can't. Anyway, you can see over there in the 8%. They had by far the lowest rehospitalization rates, and they also had by far global functioning at the end of 3 years. That 1.7 is what they were functioning at the end of the study. And you will notice, at least in this study, the rehospitalization rate was highest for those continually maintained on drugs, on antipsychotics. So what does Rappaport conclude? Again, this is his words, and it's basically the same sentiment. If we're interested in long-term outcomes and also functional outcomes, maybe we need to rethink this form of care. Okay, that's the finding here. And you can see in his own words about this. And he's talking about social functioning too. Okay, the next such study of this sort was done by Lauren Mosher. Lauren Mosher at this time was the head of schizophrenia studies in the NIMH, so he's our top schizophrenia doctor in the country. And the way this study was designed was this. People came into the hospital. They're either put into the hospital and treated conventionally with antipsychotics there, or they're taken to a home, which is staffed by ordinary people that just basically will be with people in this state. And those sent to the home they weren't put on antipsychotics right away. They might be put on benzodiazepines to help people restore sleep-wake. And then if they didn't get better in 3-4 weeks, then they were put on antipsychotics. So it's a delayed use model. And you'll see here that at the end of 2 years, those treated in this experimental manner had better outcomes, okay? And this actually is data collected from 2 such houses. In terms of antipsychotic use in this Soteria group, 42% never needed to go on the drug, 39% used the drugs temporarily, and 19% needed the drugs full-time. So what you're seeing here, by the way, is some evidence that maybe a selective use model, which figures out for whom and for how long, will produce better outcomes. This is not a no-drug model. It's a selective use model. Here's his conclusion. And again, you'll see the repeating theme. If we're interested in, longer-term outcomes, maybe we need to revisit our belief that these medications are always essential over the long term. So you'll see this recurring theme. The third such study at this time was done by William Carpenter. William Carpenter is still a famous figure in American psychiatry. This was done in-house at a hospital run by the NIMH, and it was done this way. Over the course of several years, they had 49 patients come into the hospital. Everyone was treated with psychotherapy and psychosocial care. 22 were put on drugs, 27 were not put on drugs, and at the end of 1 year, you'll see that the relapse rate is slightly lower, again, for the non-drug treated patients, and the non-drug treated patients also suffer less from depression, retarded movements, etc. So 3 studies all come up with the same conclusion. Higher relapse rates for those treated conventionally as a group, and not quite as good social functioning. So at this moment, Carpenter raises a really profound question. So think of the evidence base he has now. He has evidence showing that the drugs work over the short term. He has evidence showing that once you go on the drugs, a lot of risk of relapse when you come off. But over here he has evidence that if some people are never put on drugs to begin with, they're going to have lower relapse rates. It's a confusing bit of evidence. And he raises this question. We raise the possibility that these drugs over the long term make people more biologically vulnerable to psychosis, that they're causing some change in the brain that actually increases this risk. And here's why this is so profound. All drugs have risks and benefits, right? We know antipsychotics have a lot of risks associated with them, adverse events. Carpenter here is worried about the benefit side of the equation. He's worried that they're worsening the very symptoms they're supposed to treat. Now, at this point, 2 Canadian investigators put together a hypothesis for explaining what is happening. And here's, real quickly, is the hypothesis. How do antipsychotics work? How do they act on the brain? Neurons communicate in this way. You have a presynaptic neuron, which releases a chemical messenger, in this case dopamine, into the tiny gap between neurons. That molecule then binds with receptors on the receiving neuron. We say it fits like a key into a lock, and that's how messages get passed. So this is an illustration of just a normal functioning, communication. So what do antipsychotics do? What antipsychotics do is they block the receptors for dopamine on that receiving neuron. Where is this thing? I guess I can't. But the point is here, this is to reflect that the drug is now blocking these receptors. And so dopamine can no longer, in other words, dopamine can no longer find these receptors. So the drug is acting like a brake on dopamine transmission, right? So the brain being this very neuroplastic thing, what does it do? It tries to put down the accelerator on dopamine transmission. And it does so by increasing the density of receptors on the receiving neuron. And that's what's being drawn here, okay? So think about this. You go on an antipsychotic. It works by blocking dopamine, thwarting dopamine transmission. That acts as a brake. Now your brain puts down the accelerator, all right? This is your new brain on drugs. Now take away the brake. What do you have down? The accelerator. So what these researchers are saying is this is why you get such severe symptoms. This is their hypothesis when you go off the drugs. But he's also saying this is why even if you stay on the drugs, you might have a trouble because you've had this change in the brain, where this is the hypothesis making people more biologically vulnerable to psychosis. And here's what they wrote. You can read this. He said the brain now is super sensitive to dopamine, and this ultimately, at least in some people, can lead to new and more severe symptoms, and also is why you have such a risk when you come off the drugs. All right? So you can see what the researchers are doing. They're putting together this very complex explanation for what seems like paradoxical information. And my own opinion is this is a moment of brilliant science because it's illuminating this paradox that came through this literature. Okay, what literature? That was the picture that arose by the early 1980s. And we're going to try to finish this up now in the next 15 minutes or so. So now the question is, there's this worry arises, we're making people more chronically ill. Now, since then, do we have any other information that either puts this worry to rest, saying it's not a problem, or do we have new information that causes us to worry that these medications may in fact be worsening long-term outcomes in the aggregate? And I want to really emphasize in the aggregate is what we're talking about. This does not mean that nobody does well on antipsychotics. Some people will say, boy, these have saved my life. We're just talking about aggregate outcomes. Well, one of the things that happens in the 1990s, of course, is we get MRI technology. We can now image of brain volumes. So someone did this with monkeys. They gave the monkeys, macaque monkeys, either an older antipsychotic or a newer antipsychotic, and they gave them at a dosage that is appropriate for the monkey's weight. And let me pause here. The information you're about to hear, it can be really disturbing, and I'm actually sorry about that. The question is, do we make this information known, or do we sort of keep it hidden? And I think, as a journalist, I felt my obligation is, in fact, to let information be known, but it can be upsetting. So you can see here what they found is the brain volumes decreased in the course of 2 years on the monkeys put on these drugs. So what do we find out in humans? Well, the best such study of this sort was done by Nancy Andreasen. Nancy Andreasen is the former editor of the American Journal of Psychiatry, so she's a very famous person in American psychiatric research. Beginning in the 90s, she did a very large MRI study. It had about 500 newly diagnosed schizophrenia patients in it, and her hypothesis was schizophrenia is a neurodegenerative disease characterized by brain volume loss over time. So she expected, her hypothesis was, we will see shrinkage in the brain over time with people so diagnosed, okay? But she's going to say it's the disease, not the drug. So in 2003, she reports that that's what we're finding. There is this brain volume loss over time, okay? So next she has this question. She's still investigating a disease process. As this happens, as you get this shrinkage in the brain, what happens to symptoms? And she says, as you get a worsening of the negative symptoms. That's the emotional lethargy. You get an increase in functional impairment, and you also get an increase in cognitive impairment. So she's saying, here's our problem right now. We have this disease process, and our drugs, unfortunately, don't arrest this degenerative process. They're ineffective. But Nancy Andreasen has a problem, right? Is it the drug or the disease? Because all the patients in her study are on the drugs. So she investigates that question. And in 2011, here's what she reported. The loss in brain volumes is associated with drug exposure and even dosage, and not by the severity of the illness and not by substance abuse. Now, I think if Nancy Andreasen were standing up here right now, she says, oh, I think maybe it's a combination, that there's some degenerative process and the drugs exacerbate that. However, I will tell you there's been somehow 3 longer-term MRI study of brain volumes in schizophrenia patients who were never exposed to drugs. And in those 3 studies, there's no significant difference in brain volumes between the diagnosed patients and the healthy controls. I think it's still an open question on this. But you see why this is so upsetting? You have an agent, an outside agent, the person takes. The consumption of that agent is associated with a reduction in brain volumes, a morphological change. And as that change happens over time, 2 and 5 years, you're actually getting a worsening of symptoms, emotional symptoms, functional impairment, etc. This is dosage related. This might be a good reason to go low dosage, okay? So it is very much dose related. Okay, I got to do this real quickly. How about other studies? We have World Health Organization studies that compared outcomes. There were 2 studies, one 2 years, one 5 years of schizophrenia patients that compared outcomes in 3, quote, developing countries, India, Nigeria, and Colombia, with outcomes in the US and 6 rich countries. And you'll see each time the outcomes in the poor countries were much better, specifically India and Nigeria. And in particular one, they had much better social outcomes. And this actually, it was this study that really first provoked my curiosity and made me want to write about this, because they concluded, the World Health Organization, that living in a developed country is, quote, a strong predictor you won't fully recover from schizophrenia or that you'll have a poor outcome. And so I wondered, why would living in a rich country with all its advanced medicine and social supports be a predictor you'll have a poor outcome? Now, the World Health Organization investigators, after the first 5-year study, hypothesized maybe the reason is patients in the poor countries take their medications more regularly. They're antipsychotics. They're more medication compliant. It's a valid hypothesis. Medication compliance, if the drugs are helpful, should indeed lead to better outcomes. So they measured medication usage in the second study, and you can see the report. In the poor countries, they did use antipsychotics acutely, but only 16% of patients were regularly maintained on the drugs, where, of course, in the US and other rich countries, that's the standard of care. So at least in this cross-cultural study, there were better outcomes in poor countries where people were not maintained on the drugs. And you'll see when they came back 15 to 20 years later, the outcomes in the poor countries were much, much better. Okay, so in this very short time, we really have 2 stories out there. We have a story out there that antipsychotics are absolutely essential. You go off, you relapse at high rates. We have evidence why you want to stay on the drugs. Now, in the past 20 minutes, I've told you another story that says, well, listen, there's another sort of paradoxical study, and at least in the outcome, maybe we're worsening outcomes, functional outcomes, and maybe, in fact, we're increasing psychotic symptoms over the long term. Now, imagine going back in 1980, we have a study where we enroll 200 newly psychotic patients, and now we're going to follow them for 20 years. And everyone's going to be treated with drugs in the hospital, and then they're just going to get discharged. And we're going to follow up with them at 2, 4.5, 7.5, 10, 15, and 20 years. And as we do this follow-up, we're just going to see if they're taking antipsychotic medications. Now, if the first story is predictive, we should see better outcomes for those who stay on the meds. If the story of science I've told you here tonight is predictive, we should see something different, okay? Because science hopefully will be predictive. By the way, this study, when it was funded by the NIMH, it was funded with the purpose of finding out what happens to people diagnosed with schizophrenia or milder psychotic disorders go off their drugs after they leave the hospital. And the expectation was they will do horrible. That was the reason for this being funded. Okay, it was done by Martin Harrell at the University of Illinois. You can see at the end of 15 years, he started with 200 patients recruited from a public and private hospital. At the end of 15 years, he still had 145 patients in his study, which is a really good follow-up number. It's hard to follow up 77% of your patients for 15 years. You'll see 64 had a diagnosis of schizophrenia, 81 with milder psychotic disorders. It's a young cohort, many first episode. And now we'll just look at the data, okay? Okay, anxiety symptoms. You'll see at the end of 2 years, anxiety symptoms. This is the 64 schizophrenia patients. Those who are off medication, those who are on, about the same. By the way, 25 of the 64 schizophrenia patients got off antipsychotics, which is really Oh no, 20 of the 64. Sorry. It was either 20 or 25, I'm sorry. But it was a fair number who got off of the 64. And you'll see here a remarkable thing. Okay. Here's what's, I don't know what's going on. Here's what's remarkable here. This is the only place in the research literature you see what might be happening between 2 and 4.5 years. The relapse studies don't tell you anything about this capacity to heal. This is the only place in the literature you see what might be happening longer term. And it's actually pretty good news, right? You see a lot of healing going on between 2 and 4.5 and those off medication. Unfortunately, you're actually getting worse anxiety for those staying on. And remember the drugs were called major tranquilizers? This is the opposite of what you're seeing. You're seeing a lot of agitation. And what the worry is that people are suffering what is something called tardive akathisia. Akathisia is this inner agitation that is sometimes associated with neuroleptics. Okay, that's the anxiety symptoms. This is cognitive function. You can see at every follow-up the off-med group has better cognitive function. Now that is consistent with the data from Nancy Andreasen, who said with extended use you're getting some cognitive impairment. Okay, this is sort of a big one. If what's called dopamine supersensitivity, what we saw back in the 1980s when those Montreal investigators raised the hypothesis that these drugs were making people more biologically vulnerable to psychosis, so at that's 10 and 15-year follow-up, those who stayed on drugs were much more likely to still be having active psychotic symptoms. Okay, this is completely contrary to what the relapse studies are telling you. Okay, this is just the global outcomes for all the schizophrenia patients in the study. Again, look at when the divergence happens. It happens between year 2 and 4.5. This is the only place we see this possibility of healing. By the way, those who got off their medications and did well left the system. Okay, they did not come back to their doctors. Martin Harrell followed them up, but those who got off their drugs and did well stopped identifying as, quote, as having schizophrenia. Okay, this is the recovery rate. Now, to be in recovery in this study, you had to be working 50% or more of the time, or in school 50%. So it wasn't just stabilization of symptoms, there was a functional component. Again, you'll see at the end of 2 years, there's not much difference, 20% recovery rate for those off med versus 6% for those on meds. Again, it's between year 2 and 4.5. The separation happens. And you'll see the recovery rate is 40% for those off meds, 5% for those on. That's what it stays throughout the 15 years. By the way, the reason there's such a low recovery rate for the medicated group is they're just not working. That's the problem there. Many of them are having okay symptom control, although you saw at the 10 and 15 a lot of psychotic symptoms, but part of the problem is they're just not working. Okay, Martin Harrell has 3 outcomes. He has recovered, so-so, uniformly poor. You'll see in those who stayed on antipsychotics, 5% recovered, 46% so-so, 49% uniformly poor. For those who got off, it's 40% recovered. This next number should be 44%, sorry about that, and 16% uniformly poor. So it's not just that there's a higher recovery rate, there was many more people in the uniformly poor category that stayed on medications. So what did he say? What did Martin Harrell, the best long-term prospective study in the literature, what did he tell the American Psychiatric Association in 2008? Those of you, most everybody, of course, speaks Italian. You can see. If anybody doesn't speak Italian, he says, I conclude that people off antipsychotic medication, people diagnosed with schizophrenia, have significantly better global outcomes over the long term. This is the best such study we have. Now, how many of you have heard about this study? This study was so upsetting. First of all, Martin Harrell was told, do not publish. It's bad for psychiatry. And it just did not get promoted. And imagine if the outcomes were the opposite. Do you think there would be some initiative to make this known? There would, right? Because there's basically a financial force behind it to publicize results of the other sort. Okay, this is just the milder patients, those with milder disorders. Once again, you'll see those off medication did better over the long term. By the way, if you want to grab a very optimistic bit of information from this data, these people are doing really well. There's a lot of recovery here. I mean, basically, if you look at these off and more than 50% got off, they're in the recovered category as a whole. There was a lot of employment. So one of the things we can discover here is the capacity to recover, to really get well. That's one of the things I think history and science is telling us is these are not necessarily always chronic conditions, and we need to rediscover this thought that maybe they can be episodic. And I'm almost done here. This is really, I think, a troubling graphic. So Martin Harrow ends up with 4 groups, right? He ends up with schizophrenia on and off, milder disorders on and off. You'll see it's those with milder disorders off does best, the bottom one. The next best is schizophrenia off, then milder disorders on and schizophrenia on. The reason this graphic is so upsetting is schizophrenia has a worse prognosis than milder disorders at the beginning, right? So how come schizophrenia off is better than milder disorders on? Now, we can have a debate, and I'm sure there's lots of people who have different ideas. My thought is that is consistent with the idea that the medications over the long term are actually an iatrogenic force. In other words, they worsen long-term outcomes. That's how I interpret this data. Other people might interpret it differently. But I think you can see why we at least need to know this data and think about what is going on. Because I think we all do know what we want is the best outcomes for people. Now, real quickly, and then we'll finish up. So you've heard a different history of science tonight. What conclusion might you draw in terms of how best to use the medications from this history? And I think there's 2 pieces. If you look at first episode psychosis, can you have some sort of intensive psychosocial care, maybe with use of benzodiazepines to restore sleep-wake, and see if you can get those people through that first crisis without going on antipsychotics? Because remember the Rappaport study? Remember the Mosher study? Remember the Carpenter study? There was a number of people that could get better. So if at first episode, if you can treat without going on, you're going to have this subset that sort of has an episodic illness and gets on with their lives. And then the second idea is, okay, if you need to use the medications, then try to figure out who needs to stay on them and who needs to use them only a short term. It's not an anti-medication model, it's a best use model. And what's so brilliant about this story is that there is a group in northern Finland, in western Lapland, that began using the antipsychotics this way in 1992. And now they've been doing this for 20 years. Every single first episode patient is treated in this way. Intensive psychosocial care, use of benzodiazepines if necessary, and they try to avoid initial use of the drugs. Since they adopted this form of care, they now have the best outcomes in the Western world by far. They have 80% of their first episode patients who are working or back in school at the end of 5 years, and only 20% have gone on to disability. And in terms of antipsychotic use, 2/3 of their patients have never put on antipsychotics at the end of 5 years. So that means 33% have. 13% only use them temporarily, and then 20% need to be on them long term. So this is a best use model. Now, one of the things that happened after I wrote this book in 2010, now this is a story that really is provocative. There's, I've given this talk to many different groups. Some groups aren't so happy with this talk. But after this book came out, a foundation formed in the United States, and they raised about $3 million with the idea of doing more research on long-term outcomes, but also funding replication projects to see if we could start treating first episode patients in this manner. There are 2 such projects now underway, and here's what's important. Prior to this information sort of being put together, it was considered unethical to not put a psychotic patient right on drugs right away. And these 2 groups, both associated with medical schools, in order to get these pilot projects underway, had to go to what are called institutional review boards. These are boards that review experiments to make sure they're ethical. And they convinced those institutional review boards that this science tells a different story and there's a rationale for doing it this way. So for me, this was sort of confirmation that this is valid science if you really look closely. And 2 things. again, up until recently, the idea that antipsychotics might be a problem just was not, on the table, so to speak. Read this from British Journal of Psychiatry. They're saying it's time to rethink our use of these drugs, and there should be a phrase in there, because to put it bluntly, they simply may not be worth the candle. Is that in there, the translation? Meaning that the adverse events and even these psychotic symptoms, these things may make them not worthwhile. And the very final thing is this. So this coming from a mainstream British Journal of Psychiatry. In this month's issue of Schizophrenia Bulletin, again, a biological psychiatry type journal, mainstream journal in the United States, Martin Harrow has a new article saying, here's what we need to address. Do these drugs make people more psychotic over the long term? And he says one thing is quite clear. There are many people who would do better off the medications long term, and what we need is a paradigm of care that figures out who can do better off and who needs the drugs. So what might seem radical, might seem crazy, that was peer-reviewed. He reviewed the science. He actually went back over a lot of this stuff I had put together. And when it was peer-reviewed, the editors finally said, yes, we need to be thinking of this. Now, that hasn't happened in 50 years. So there is this discussion that is changing. So that's the story for antipsychotics. There's a story for antidepressants, I will tell you, has some similarities in terms of worsening long-term outcomes. And it's critical that the doctor, the researcher, who's really bringing that question to the forefront is an Italian named Giovanni Fava from Bologna. So, and he's been sounding this theme for about 20 years, and there's plenty of reasons why he's doing it. So anyway, what I think history and science are telling us, and going back to this medical mystery, I think the drugs are useful. I mean, I think there's a place for them, over the short term, and then some people, over the long term. But they are also problematic. They're problematic because once you go on, the brain adapts to the presence of the drug, which makes going off very perilous. But if you stay on, the drugs actually have this thing where they cause the opposite effect of what is originally intended by the drug. And what researchers are saying is the brain is trying to maintain a homeostatic equilibrium, and this is why these drugs sort of fail over the long term. So I think we as a society, and hopefully the medical establishment, really needs to confront the rising disability data, this paradoxical outcomes for long-term outcomes, and confront it with this idea. As we all know, pharma companies pay doctors, that whole thing. But there's sort of a societal responsibility to say, what do we do to our fellow human beings to help them through times of psychiatric problems? And what we don't want that answer to be governed by money. What we want it to be governed, of course, is by how do we best help people. And I think science and history are telling us we really need to rethink this paradigm of care. Thank you.